Hello, this is the fourth lecture of this course on interpreting ABGs, and I'm Eric Strong from the Palo Alto Veterans Hospital and Stanford University. Today I will be discussing the phenomenon of compensation and the diagnosis of mixed acid-base disorders. The learning objectives are as follows. First, to understand the basic mechanisms of physiologic compensation as they relate to interpreting ABGs. Second, to be familiar with the specific compensation formulas and their alternatives. Finally, to be able to use an assessment of compensation to identify the presence of a second acid-base disorder. The topic of compensation was first introduced in Lecture 2, but to remind you, the body attempts to compensate for acid-base disorders in such a way as to mitigate derangements of arterial pH. A primary metabolic disorder will result in respiratory compensation. A primary respiratory disorder will result in metabolic compensation. Compensation does not return the pH all the way to normal, and patients never overcompensate. Let's take a quick look at the very basic mechanisms of compensation for the four general types of acid-base disorders. In a metabolic acidosis, the serum bicarb is abnormally low, and thus so is the pH. The body's response to this, that is, its respiratory compensation, is to increase minute ventilation. Increasing minute ventilation lowers PCO2 and thus tries to increase pH back closer to normal. In a metabolic alkalosis, the bicarb is high and thus so is the pH. The body responds by decreasing minute ventilation, which increases PCO2 and drives pH back down somewhat. In a respiratory acidosis, PCO2 is too high and the pH is too low. The body's metabolic response is to absorb more bicarb in the proximal tubule of the kidney and to increase excretion of hydrogen ions in the distal tubule. This increases serum bicarb and helps to increase pH. Finally, in a respiratory alkalosis, PCO2 is too low and the pH too high. The kidneys then reabsorb less bicarb and excrete less hydrogen ions. Before I move on to talk about how we can use the phenomenon of compensation to help diagnose mixed acid-base disorders, there are two other aspects of compensation that I need to quickly mention. First, the speed with which compensation develops after the onset of an acid-base disturbance is very important, as we'll see shortly. How fast do these processes occur? The respiratory compensation for a primary metabolic disorder is measurable within minutes, but may take up to 24 hours to be maximally stimulated, depending upon the circumstances. The metabolic compensation for a primary respiratory disorder takes a bit longer. I've seen estimates of anywhere from 12 hours to 5 days. I think no one really knows for sure because, as with much of acid-base analysis, this time delay is largely estimated from observations in healthy volunteers and may not strictly apply to critically ill patients. The second additional aspect of compensation I need to mention is that the body's compensatory mechanisms for a metabolic alkalosis is relatively poor compared to that of the three other major classes of acid-base disorders. As I recently mentioned, the body compensates for metabolic alkalosis by decreasing ventilation and thus increasing PCO2. If you remember the alveolar gas equation shown here, you might see that by increasing PCO2, P big A O2 will necessarily decrease. That is, the partial pressure of oxygen in the alveolar space will be low, which will result in a lower arterial partial pressure of oxygen. In other words, hypoventilation will necessarily lead to some degree of hypoxia. In patients with normal gas exchange at baseline, hypoxia is a strong stimulus to breathe more. This hypoxia-induced desire to increase one's ventilation significantly blunts the relative hypoventilation driven by metabolic alkalosis. So now how can we use compensation to identify mixed acid-base disorders? By predicting the normal compensatory response to primary acid-base disorders, mixed disorders can be identified. Specifically, if a given patient is not compensating as predicted, a second or even third acid-base abnormality must be present. For example, imagine you have identified the presence of a primary metabolic acidosis in a patient in whom the serum bicarb is 10 milliequivalents per liter. From an equation I'll show shortly, you would predict that the PCO2 should be approximately equal to 23 millimeters of mercury due to respiratory compensation. However, what if the patient actually has a PCO2 measured at 35 millimeters of mercury? What's the possible explanation? A second primary acid-base disorder must be present. In this particular case, since the PCO2 is higher than predicted, it is consistent with the concurrent presence of a primary respiratory acidosis. In order to predict what the expected compensation should be, generations of previous researchers have empirically derived a set of formulas with a different one for each primary disorder. In fact, to make things even more complicated, there is actually more than one formula in common usage for each disorder. The following chart represents the formulas which, in my experience, appear to be the most commonly used in the United States. For a metabolic acidosis, the compensation formula is as follows. PCO2 should be approximately equal to 1.5 times the bicarb plus 8. This is known as Winter's formula, named after Robert Winters, a pediatrician from Columbia University who helped derive it in the 1960s. For a metabolic alkalosis, PCO2 should be approximately equal to 40 plus 0.7 times the difference between measured bicarb and 24. For respiratory acidosis and alkalosis, it depends upon whether the pathologic processes are acute or chronic. Remember, it takes anywhere from 12 hours to 5 days for a respiratory process to become chronic as it pertains to acid-base balance. For an acute respiratory acidosis, the bicarb should be approximately equal to 24 plus the difference between measured PCO2 and 40 divided by 10. For chronic respiratory acidosis, the bicarb should be 24 plus 4 times the difference between PCO2 and 40 over 10. For an acute respiratory alkalosis, bicarb should be 24 minus 2 times the difference between 40 and the PCO2 over 10. And finally, for a chronic respiratory alkalosis, bicarb should be 24 minus 5 times the difference between 40 and the PCO2 over 10. How much variation is allowed for by the approximately equal sign here? For example, it's very common for people to cite Winter's formula as PCO2 equals 1.5 times bicarb plus 8 plus or minus 2. Owing to substantial variation in compensation between different individuals and between different specific acidoses or alkaloses, the confidence intervals for these equations should likely be much wider. One authoritative source cites a plus or minus of 5 millimeters of mercury for PCO2 when estimating respiratory compensation for metabolic disorders, and plus or minus 3 milliequivalents per liter of bicarb when estimating metabolic compensation for respiratory disorders. This wider range of error appropriately reflects the degree of uncertainty we have when diagnosing complicated acid-base disturbances. As I mentioned before, there are some alternative approaches to calculating compensation. I won't go over all of them, but here is one alternative to calculating compensation for respiratory disorders. For an acute respiratory acidosis, bicarb should increase 1 milliequivalent per liter for each 10 millimeters of mercury the PCO2 is above 40. For a chronic respiratory acidosis, bicarb should increase 4 for each 10 the PCO2 is above 40. For an acute respiratory alkalosis, bicarb should decrease 2 for each 10 the PCO2 is below 40. And finally, for a chronic respiratory alkalosis, bicarb should decrease 5 for each 10 the PCO2 is below 40. The astute viewer may recognize that these shortcuts are actually mathematically equivalent to the equations presented on the last slide, but most people find it easier to remember these relationships when it's presented in this manner. There is actually an extremely easy alternative to calculating compensation for metabolic disturbances. In a metabolic disorder with appropriate compensation, the PCO2 in millimeters of mercury is approximately the same as the first two digits of the pH after the decimal point. To see what I mean exactly by that, here is a quick example. In this ABG, the pH is 7.27, the PCO2 is 25, and the bicarb is 11. Now take the first two digits of the pH after the decimal, which in this case is 27, and compare it to the PCO2. They are approximately equal to one another. Therefore, there is appropriate physiologic compensation for this metabolic acidosis. I've been teaching acid-base disorders to house staff and students for some time, and I initially hated this particular shortcut because it seemed that a trick so simple couldn't possibly be as accurate as necessary. However, I have since conceded that I was wrong on this. Here is a graph where measured serum bicarb in a metabolic acidosis is on the x-axis, and the predicted PCO2 as a result of compensation is on the y-axis. The blue line here represents the PCO2s that are predicted by the shortcut. For example, in a metabolic acidosis with a bicarb of 16, we expect the PCO2 to be about 31. How does this formula compare to predictions from the empirically and scientifically derived Winters formula? I'd say it's pretty darn close, especially once you are dealing with bicarb levels under 20 mole equivalents per liter. How does this shortcut compare to the formal compensation equation for metabolic alkalosis? Here is the shortcut's predictions of PCO2 over a range of serum bicarbs from 24 to 40. And here is the formal equation. This is definitely an approximation that is close enough to use at the bedside. So now let's go through 3 quick examples to see how an assessment of compensation works in practice. Here is example 1, where the pH is 7.50, the PCO2 is 48, and the bicarb is 34. Steps 1 and 2 of acid-base analysis remain the same, checking the pH, and then the PCO2, and then step 3 will be evaluating compensation. So first, the pH of 7.50 is higher than normal, so therefore this patient has an alkalemia and at least one alkalosis. Next, look at the PCO2 of 48. This is higher than the normal PCO2 of 40. Since the pH and PCO2 are deranged in the same direction, the problem here is metabolic in origin and thus a metabolic alkalosis. Now for step 3. We will take a look at the compensation formula for metabolic alkalosis, which states that the predicted PCO2 should be approximately equal to 40 plus 0.7 times the difference between measured bicarb and 24. Is that true in this case? Yes. Therefore, we'd say that this patient has appropriate respiratory compensation. Using the shortcut method, 50 from the pH is approximately equal to 48 from the PCO2, and we reach the same conclusion. Let's move to example number 2. The pH is 7.12, PCO2 is 32, and bicarb is 10. Step 1, check the pH. pH is low, so there is an acidemia. Step 2, check the PCO2. The PCO2 is also low, so the process is metabolic and thus a metabolic acidosis. Step 3, evaluate compensation. For this, we will use Winters formula. So does the PCO2 approximately equal 1.5 times the bicarb plus 8? 32 is not close enough to 23. Therefore, a second disorder is present. Since PCO2 is higher than predicted, this second process must be a respiratory acidosis. Using the shortcut method, 12 from the pH is not approximately equal to 32 from the PCO2, and again we reach the same conclusion that respiratory compensation is not appropriate. Example number 3. In this case, we have a brief clinical vignette. A 24-year-old man is found unresponsive on the floor, soiled with vomit. He was last seen 4 hours prior and appeared well at that time. His ABG is as follows: pH 7.34, PCO2 65, bicarb 34. Step 1. pH is low, so there is an acidemia. Step 2. The PCO2 is high, so there is a respiratory acidosis. Step 3. Evaluate compensation. From the vignette, it seems highly likely that the pathologic process in question is acute in onset. Therefore, we will use our shortcut for an acute respiratory acidosis. Is the bicarb increased by 1 milliequivalent per liter for each 10 millimeters of mercury the PCO2 is above 40? Since the measured 65 is 25 above the normal 40, and 25 is 2.5 times 10, we would expect the bicarb to be 2.5 milliequivalents per liter above normal. You should generally use 24 as a quote normal bicarb for acid-base problems. Therefore, the expected bicarb from this respiratory acidosis would be approximately 26.5. This is significantly different from the measured bicarb of 34. Thus, a second disorder is present. The bicarb is higher than predicted, so the second disorder is a metabolic alkalosis. You might have expected this conclusion from the fact that despite a moderately elevated PCO2 of 65 on the ABG, the pH of 7.34 is remarkably close to normal, and as I've said before, compensation never returns your pH to normal. So that's a little bit about the phenomenon of compensation in acid-base disorders and how to use compensation to identify the presence of an additional acidosis or alkalosis. In the next lecture, I will talk about the anion gap.